Right, okay, so hi everyone, and tonight we're here to talk about GI bleeding. So the end of this session is apparently essentially to cover every single aspect of GI bleeding. That's what it feels like at least. So we're going to look at the clinical features of GI bleeding, the different types and causes. Yes. We'll discuss imaging and suspected GI bleeding and going into the management with a particular focus on IR procedures that can help, okay? We're not likely to go through it in a nice, beautiful order like this, but we will attempt to cover all of these things, all right? So, you're the FY1, okay? And you're on for medicine, surgery, you're in the ED, you're on a care of the elderly ward, you're just about anywhere in the hospital, okay? And this situation can come up, okay? So you get called and asked to see a patient. Nurse on the phone tells you that they've got a 71-year-old woman who's been admitted with stomach pain, and they've just vomited what looks like blood, all right? Now, one of my pro tips for being the foundation doctor that is the first person who's called to come and see patients, you've been phoned and told that a patient is vomiting blood, okay? And that this is new. You're going to see them, all right? And unless you've got several other unwell patients that you're about to see, you don't actually need any more information right now, okay? You're going to go and see them. And actually, it can be really helpful to just say to the nurse, I'm coming, can you get a new set of obs, please, and a blood sugar, okay? Because that covers you for every situation. It means that when you get there, you've saved time on the phone, you save time when you get there because there's an up-to-date set of obs, and actually you've increased your chances that the nurse looking after the patient is going to be around when you arrive to tell you where the notes are and give you any other information and stuff you need about the patient. So you get there, and what are you going to do? You're probably all absolutely sick of A, B, C, D, E, but I don't care. It's really important. And even now, you know, like as an ST5, like I go back to this when I'm faced with, for example, a patient that's collapsed in the CT waiting room, because those are the sorts of patients that I get called to see, and it just gets you out of trouble. It helps you think really clearly. So I don't apologize for doing it again. Okay, so you ask Mary how she's feeling. She says, "Oh, I'm a bit rough, doctor. Sorry, airway's fine." Okay, she's talking to you. Nurse gives you the up-to-date obs. So their respiratory rate is 22, her oxygen sats are 98% on room air. Blood pressure is a little on the low side at 110/75. Heart rate's up a little bit at 105. She's apyrexia and her BM's fine at 9.8. Listen to her chest, which is clear, and a capillary refill is about 2 seconds. So remember to look at the trends though, okay? So these obs are maybe you're maybe just a little bit concerned, something's clearly quite not right. But if that heart rate has been tracking up and that blood pressure tracking down for the past 4 hours, you're more concerned, okay? And one of the most important things in these patients is also exposure, okay? You need to look at the vomit. Is it fresh red blood? Does it look like coffee grounds? Because coffee ground vomit actually does look like coffee grounds. That's why it's called coffee ground vomit. Has the patient just drank an entire bottle of red cola and vomited it back up? Okay, so these are all things that you need to know about. Okay, so look at whatever fluids the patient is producing, as well as exposing and looking at the patient. So with Mary, you pull back the covers, and before you see anything, you're hit by a distinct smell, and you realise that you'd recognise it anywhere because you smelt it before about 6 weeks ago on your on another rotation, but it's melena. Okay, and you can see that there's melena kind of staining the bed and things as well. So this sounds like an upper GI bleed, right? But what does that actually mean? So an upper GI bleed is where the source of bleeding is before you get to the ligament of Treitz, which is also called the suspensory ligament of the duodenum. And it's around about the DJ Fletcher, which is marked just on this diagram over at the right side of the screen there. So that's the junction between the duodenum and the jejunum. So anything after that is counted as a lower GI bleed. So the lower GI bleed actually encompasses a lot more volume of the GI tract than our upper GI bleed does. Let's compare the two. So we've talked about some of the features of upper GI bleed already. So you can have fresh hematemesis, coffee ground vomit, which is partly digested blood that's been brought back up, and melena, which is also partially digested blood but is being passed per rectum. Patients can also have a hemoglobin drop, hemodynamic instability, and their urea can rise. That's actually another product of digesting the blood. That's what makes the urea rise. In lower GI bleeds, you can also still have the hemoglobin drop and the hemodynamic instability, but they tend to have a more fresh looking PR blood that has a fancy name that I'm not really sure how you meant to pronounce. We're going with hematochezia. And they can have blood, they can pass blood that looks quite fresh but is mixed in with stools and things as well. A caveat to all this though is that a really big upper GI bleed can present with fresh PR blood if there's enough bleeding. The two do have quite different causes though. So for upper GI bleeds, we've got peptic ulcer disease, varices, mucosal inflammation, malady Weiss tears, things like vascular abnormalities and malformations, like a Delafoy lesion, vasculitis, aortoduodenal fistula, which is a pretty catastrophic thing, where quite literally there is an abnormal connection between the aorta and the duodenum. And you can have tumours and things as well. The list for lower GI bleeds is a bit smaller: diverticular disease, angiodysplasia, colorectal cancer and polyps, inflammatory bowel disease, and hemorrhoids. With the lower GI bleeds, things are a bit more evenly split. Diverticular disease and angiodysplasia are potentially the most common that cause really serious bleeds. But for upper GI bleeds, the horses are definitely peptic ulcer disease and varices, and these account for a huge proportion of the upper GI bleeds that you'll encounter. So let's go back to wee Mary, all right? So you've assessed her, you think she's having GI bleeds, okay? So what do you want to do? So you need to think about the basics first. Make sure there's good venous access, ideally 2 good cannulas. Take bloods, consider what immediate resuscitation is required, okay? Do you want to give a fluid bolus? Actually, is the patient really unwell and you need to put out a peri-arrest call? Is the patient emergently needing blood and we need to think about activating the major hemorrhage protocol? When you take bloods, the important bloods are all of the ones around the hemoglobin, the clotting, and getting the patient more blood if they need it, okay? So you need a full blood count, coagulation, and at least a grip and save. But if you think a patient is actively bleeding, I would suggest getting a cross match before you need it rather than waiting until you could really be doing with the blood right now. A venous blood cast can be really helpful in the acute setting as well. You'll get an instant estimate of their hemoglobin. You get urea in most venous blood gases as well. And you'll get a bit of a measure just of how unwell they are as well. Is their lactate raised? Are they becoming acidotic? You need to check the patient's medications. If they're bleeding, are they on warfarin? And their last INR was 6. Okay, you want to correct any coagulopathy, speak to hematology if you need to. And then we get to imaging, okay? So consider imaging. And 99 times out of 100, when you think a patient has a GI bleed, you're going to get a CT scan, okay? It's fast. Most places have excellent out-of-hours access to CT now. And from an IR perspective, it's actually really important because we can plan our intervention from it as well. We can see any atherosclerotic disease. We can see any anatomical variants, because vascular anatomical variants are really quite common. And it's pretty sensitive as well. So CT will detect bleeding of a rate greater than 0.3 mils per minute, so pretty low. If you think they're bleeding, they need a triple phase scan. Okay, more about why and that in a minute, but it needs to be triple phase. That means it needs contrast. Okay, many of these patients, their renal function will be off, but it will be really off if they stop perfusing their kidney because their blood pressure drops so low. In an emergent situation where there's suspected bleeding, the imaging is only useful with contrast. You still need to have discussion for sure. Is the patient going to be a candidate for renal replacement therapy? You need to discuss with the patient as well, make sure that they know the risks of the CT scan with the renal function. And it's worth always discussing with a senior before you get imaging. In some cases, patients might go straight to endoscopy, particularly if they've already had imaging or had a previous endoscopy and, they think they know what the issue is. And that can be particularly useful if a patient has, severe renal impairment to go straight to a treatment option. So this is an example of triple phase imaging and why we get triple phase imaging. So first off, what we mean by triple phase in this case is non-contrast, which is what I've got on the screen there just now. You want an arterial phase, and then you want some sort of venous phase or delayed phase, and that'll depend a little bit depending on where you work. The scan is done with 3 acquisitions, so the body is scanned 3 times, once without any contrast, and then 1 contrast bolus is given, and the patient's scanned again while the contrast is in the arterial system. And then they just wait a little bit longer and scan again once that same bolus of contrast is in the venous system. So you end up with 3 acquisitions, but 1 contrast bolus to get your 3 phases. So there's little to see on this non-contrast phase, okay? We can tell that this is an arterial phase because the aorta in the middle of the screen there is bright. but nothing else really is, apart from these bright spots over in some of the bowel. What is the right side of the screen to look at it, but because it's a CT scan, it's the other way around, remember? So this is on the left side of the bowel. So this is the arterial phase. So we're seeing contrast going into the lumen of the bowel here on the arterial phase. And on the venous phase, we can still see this bright, but it's changed shape. Okay, so we call this venous pooling. So this is really important. Separating the arterial and the venous phase out like this and seeing the change in the pool over that time lets us know that this is an arterial bleed and not a venous bleed. Venous bleeds are much more likely to just stop by themselves. They don't require, well, embolization isn't usually an option for them in terms of IR. So it's quite important to make that distinction. And the non-contrast is essentially so that you don't confuse things that aren't blood with being blood. If you just had this high density image, you wouldn't know that that wasn't something high density that the patient had eaten. But it wasn't on the non-contrast, so it must be contrast. This must be extravasation and active bleeding. Is there other imaging in the acute setting? The short answer is no. CT is really the only useful imaging modality in the acute setting. Rarely nuclear medicine studies can be used. These are done non-emergently, where there's thought to be a slow GI bleed or an intermittent GI bleed. It is incredibly sensitive, so it can detect bleeding down to like 0.05 mils per minute. So really, really slow bleeds. So either the radioisotope, usually technetium-99M, and the technetium-99M sulfur colloid scan is usually the one that is preferred, although they can also do labeled red cell scans as well. And after the radioisotope is injected and they wait a certain amount of time, the patient goes and lies on a gamma camera, and the gamma camera basically forms a picture based on counting the number of signals that it receives from the gamma being given off by the radioisotope. So let's go back to our patient again. So CT is diagnosed with GI bleed. Huzzah, we've got the answer, all right? So we'll discuss IR treatment in a moment, but there's some other treatment points to consider first, okay? So you need to make sure that your patient is adequately resuscitated, because they need to make it through an endoscopy or procedure, something, potentially. So make sure that they are adequately resuscitated. I know I said correct coagulopathy, but we're going to say it again. And if you phone us, we're going to ask if they're coagulopathic, and if they are, what you've done about it. So it makes sense to just fix it first, all right? And the other thing that's really important once the emergent management is done is that you need to treat whatever the underlying condition is as well. So if the patient has peptic ulcer disease, you need to think about H. pylori eradication therapy. If the patient has bleeding varices, you want to make sure that their liver disease is optimized. If they've got diverticulitis, give them antibiotics. Are surgery already involved in the patient's care? Do they need to be? So you need to think about all these things as well. In most cases, endoscopy will be the first line treatment, particularly for an upper GI bleed, but for lower as well. Usually these patients will all have an endoscopy. And this can localize and diagnose the causes of bleeding, but can also provide treatment too. So they can inject adrenaline, they can clip bleeding vessels, they can band varices, band hemorrhoids and things like that. There's NICE guidelines for upper GI bleeding, and there's British Society of Enterology guidelines for lower GI bleeding. And both of these are really pretty strong on endoscopy being an important first line treatment. So what comes to IR? When I kind of sat down and thought about this, I was like, there's three main treatment kind of patient groups when it comes to GI bleeding and IR. So there's emergent embolization, where endoscopic management has failed. So these are patients that are sick. They are unstable. They usually need done out of hours in the middle of the night whenever they present. And yeah, they have to be done quickly. There's empirical embolization. So what we mean by that is the patient is either not thought or not proven to be actively bleeding right now, and they're potentially currently stable. They might not be, but they're potentially stable. But endoscopic treatment has been tried. They don't think that it's been successful, or they're worried that they've not managed to treat completely. And they have a high suspicion that the patient is going to bleed again. So these can often wait till the daytime if the patient's stable. Sometimes it would be a case of doing it straight off when endoscopy maybe hasn't shown a bleeding point, hasn't shown something to treat, but the patient is still unwell. And the third group are cases where endoscopic treatment has failed or is not enough by itself to reduce bleeding varices. So these can be emergent because the patient is actively bleeding at the time, but they can also be done as planned cases where a patient has had recurrent variceal bleeds. So let's talk about embolization. So I found this definition. Okay, so embola is the plural of embolus, a word that comes from the Greek embolos, meaning a wedge or plug. Embolus was derived from en, which means in, and bolin, to throw. So emboli are something thrown in. I quite like that because it's quite an apt description of what we actually do in embolization, okay? So we access the femoral artery in the groin usually. It can come from above as well. Place a sheath in the groin and then use various wires and catheters to manipulate our way to whatever vessel it is that we're wanting to embolize. We usually use a bigger catheter to anchor into the main vessel, and we call that the mother catheter usually. And then we put a microcatheter, so a smaller catheter, through that to get us into the smaller branches. So what do we throw in? In the case of acute GI bleeding where I work, the answer is coils, more coils, sometimes plugs, occasionally glue, other liquid embolics, and sometimes gel foam. So gel foam is a kind of, I don't really know how to describe it if you've not seen it, to be honest, but it's a kind of weird textured material that you can cut up into bits and mix with saline to create a kind of slurry that you can then inject, and it blocks off the arteries. We've got a fair amount of choice. The only other embolic that we've not really mentioned is particles. These aren't generally used in the GI bleeding setting, and you'll probably hear about them in some of the other talks. So I'm not really going to talk about them today. So what we use, so yeah, I said where I work because which embolic is used depends on a mixture of factors, including what the operator prefers to use, what the operator is experienced in using, what's available on the shelf. That's actually a particular thing right now because there's been various stock problems and supply problems from various suppliers for different things. So you're sometimes not always quite sure what's on the shelf. And also what's required in the situation. So these embolics, they work in different ways. So coils and plugs, they work where they are deployed. So they slow bleeding and cause thrombosis, but they rely on the patient's clotting to do some of the work, which is why I was hammering the point of correcting coagulation. There's no point in trying to do an embolization with something like coils if the patient's anticoagulated or the coagulation is just not working properly. So liquid embolics, they move away from the end of the catheter with flow. So they'll occlude at a small level, but they can be a bit trickier if you're not experienced with them and you're not used to how fast they flow, how much to inject and things like that. And these methods, so the coils, the plugs, and the liquid embolics are all permanent. The gel foam is not so permanent. It dissolves over the course of a few weeks and doesn't leave anything behind. And it is also possible to use a combination. So you might occasionally hear someone talk about a coil sandwich. So that's when they'll put in some coils and then they'll put in some gel foam or another liquid embolic and then put in some more coils. Or they'll put in coils and then inject gel foam over the top of it. And these are all just different techniques in order to gain hemostatic control. You're probably familiar with these kinds of pictures of the blood supply to the GI tract, and you've probably been told about how you've got the different arteries, the celiac, the superior mesenteric, the inferior mesenteric, and they all supply these different regions and different parts. In reality, the GI blood supply is a bit more like this. Okay, with absolutely tons of collateral supply despite all of the named branches. This means two important things. Firstly, it means that any bleeding point needs to be addressed on both sides of it, or you need to be super selective to reduce the chance of any collateral flow continuing to cause bleeding. I'll explain a bit more about all that in a second. Secondly, it also means that despite everything that your common sense and your brain is telling you, as long as you're not in a major branch, you're rarely going to cause any kind of clinically meaningful ischemia by doing an embolization. You feel like these should be really high risk of causing bowel ischemia, stomach ischemia, but they just don't, and it just, in some ways, it doesn't make sense. So this is what I mean by treating both sides of a bleeding point. So we call it closing the front door and the back door. So here we've got the duodenum curving around the head of the pancreas with the gastroduodenal artery. And we have a bleeding point here. So this is bleeding from branches of the GD. So we go in, we get a catheter to the celiac axis and take a microcatheter into the gastroduodenal artery. And we see the bleeding. So we deploy some coils. But we don't know that this isn't also bleeding from below. So we now have to go we have to go into the superior mesenteric artery and look at the collateral branches here. So we inject contrast here to make sure that we don't see any bleeding. And if we could still see ongoing bleeding, we then put coils here too. Ideally, what you want to do is you want to get across the bleeding point from the start and coil from one side through to the other, so that when you're going into the other artery, it's just a little check. And here's some pictures showing this from a case. So the catheter in the left picture is through the celiac axis. So you can see the hepatic arteries going up to the top left of the picture. And you can see the origin of the gastroduodenal artery, which has been coiled. You can also see just to the left of the coils that there is a clip there. So that's the clip that's been placed in the duodenum at endoscopy prior to this procedure. And that's really helpful because that helps you, that just increases your confidence that you're embolizing the right artery if you don't see any bleeding at the time of the procedure. On the right, the mother catheter has now been taken into the superior mesenteric artery, and there's another catheter coming out of the tip of that that's a microcatheter. So you can see contrast going up towards more coils. But I suspect that what happened in this case, because they've got the microcatheter in there, was that they had to put some more coils in from the bottom as well. So to be able to close the front and back door with coils that are plug, you need to be able to get there, because the coils or plug are going to come out the tip of the catheter, and that is just where they're going to be. That is where they're going to embolize. That's where they're going to cause the thrombosis. Sometimes this isn't possible. That can be for various reasons. Sometimes you've got a pseudoaneurysm and the wire just coils in it and won't go out the other side. Sometimes if you've got a duodenal ulcer that's bleeding really briskly, your wire just actually goes through the hole and ends up in the duodenum, and you can't get it to follow the vessel around. So in cases, and sometimes it's actually just too small as well, and you're not going to be able to get into it. So if you're unable to get across to close the front door and the back door, then you can use glue or gel foam, because the flow will take them forward and will block it'll basically carry the embolic to the other side of the vessel and block it up that way. So they can be useful in different situations. So the other way that we can treat GI bleeding is to get into a selective branch. So these images show the kind of lattice shape that gets formed to give loads of collateral supply, with the vasa recta going out to the bowel. In the image on the right here, we've got bleeding again, and this time we've embolized a single branch that is causing the bleeding. But again, that's not a problem, because what we can see here is that you've got these tiny branches of all these mural trunks that come in. So you just don't seem to cause ischemia. However, if you were to embolize further back, then you could potentially take out a whole section of bowel, because you would have taken out all of that supply. So these are the kind of two ways that you can do this. So here's some real life pictures again. So here we've got a mother catheter in the superior mesenteric artery, and then we've got a microcatheter out, and it is demonstrating the bit that's bleeding. Okay, so I am simple. I like things to be very straightforward. And essentially, when it comes to these angiograms where you're looking for bleeding, tubes are good and blobs are bad. So in this case, you can see, I don't know if you're going to be able to see my mouse cursor, but here we've got a nice parallel tube that's filling with contrast. Contrast is staying within those parallel lines of the tube. But here, we've got a whole bunch of blob going on. Okay, so this is demonstrating some active bleeding. And in this picture, the selective branch has then been coiled to embolize it off. So that's an example of that one. So what about when we get in there? We've got an idea where the bleeding might be coming from the Scopes, the imaging, and the clinical history, but we can't see a bleeding point. It's not bleeding at the time that we're in there ready to embolize. Should we still embolize? The answer is yes. In most cases, you should. Apart from anything else, it stops you from having to come back in 2 or 3 hours later when the patient is bleeding again. But that's not actually the reason for doing it. So we do this most often in the gastrointestinal artery. So in our centre, we've got lots of peptic ulcer disease, but we also cover the regional pancreatic centre. And they quite often have issues with the gastrointestinal artery in post-surgery or in pancreatitis, because the pancreatic juices they love blood vessels, and blood vessels hate them. So it's quite common for us to do gastroduodenal embolization as an empirical thing. Embolizing it has low rates of ischemic complications, and there are some studies that have shown that outcomes are better if you embolize than if you don't. Even when you can't see a bleeding point, if you think that the patient is or has been clinically bleeding. So we'll move on to a bit of a different thing now. So variceal bleeding is another really common cause of GI bleed, but it is a bit different. So the portal hypertension in cirrhosis, it creates a back pressure that opens up lots of anastomoses and collateral pathways that exist but are usually very small. So these open in various locations. So you can get gastric varices, esophageal varices, perisplenic varices. You can get paraesophageal varices coming right up into the thorax and things too. They're also responsible for some of the clinical findings that you've maybe heard about or been taught about but never seen. So caput medusae is a collaterals opening up in the abdominal wall, and hemorrhoids are actually collaterals at the anal canal as well. And quite often, these are opening up in order to reduce the portal hypertension, but usually they're just not enough to compensate. And the varices are under pressure as well, and they bleed. There's a couple of ways that IR can help with this. First up is TIPS, which stands for transjugular intrahepatic portosystemic shunt. So here we have an IVC and a liver, all right? So we come in from the jugular vein, therefore transjugular. And we use this special kit to tunnel through the liver intrahepatic. And this creates a connection between the portal vein and one of the hepatic veins. And that is what becomes the portosystemic shunt. A stent like this one that's kind of mostly covered, but not all. So there's draft material in this top part of the stent here. But the bottom part is open. So we create the channel. The channel is the current really goes from kind of right atrium through the hepatic vein, through the liver, and into the portal vein. And then we deploy a stent across it. This stent has this open bit that's at the portal side. So this means that there's still blood flow able to go from the portal vein into the liver, but some of the blood is diverted up. So this overall reduces the portal hypertension. This is an angiographic picture of showing the channel that's been created. So this is the channel here that's been created. So this end is in the systemic circulation at the atrial IVC junction. And then these are some of the varices that we were talking about. So they're still tubular, but they're very, very tortuous and don't look like normal, nice, straight things. And then this picture here shows you can just make out the stent here. And then this ring is the transition between the intrahepatic portion, which is covered, and the portion that's here in the portal vein, which is uncovered. So one of the things that can happen though with this procedure is that you can cause hepatic encephalopathy. Essentially the liver is being bypassed by a whack of the blood supply. You can see from this picture that most of the blood supply is going up through the shunt. There's not a huge amount going off to the liver from this contrast injection. So that means that the liver isn't getting a chance to filter out all the stuff that it normally would be. So one of the contraindications for TIPS is a patient that already has signs of hepatic encephalopathy, because you're more than likely going to make that worse if you do a TIPS procedure. And there have been cases that we have to go in and reduce the diameter of a TIPS or even block off a TIPS, even though they've got a history of variceal bleeding. But we have to block off this channel that we've created because the patient's developed hepatic encephalopathy and no longer able to live independently. And it's really, really affected their quality of life. So there are other options. There's these things, Barto and Parto. So balloon occluded or plug assisted retrograde transvenous obliteration. These both have similar principles. So the varices are accessed by the venous system this time. So you need to remember that and puncture the vein and not the artery. And you take a catheter into the varices and then inflate a balloon or deploy a plug alongside that catheter to occlude the variceal shunt. And then you can inject embolization material like glue or coils through the catheter. And the role as a balloon or plug is essentially to stop whatever you're injecting, stop the coils or the gel foam moving with the flow into places that you don't want them to be. And this lets you block off some of the variceal pathways. So in my real life, we don't do a whole lot of lower GI embolization. I think lower GI bleeds significant lower GI bleeds are less common than upper GI bleeds anyway, but also they more commonly respond to conservative management and stopping anticoagulants. Embolization for upper GI bleed is much more common. And for the reasons that we talked about, we do quite a lot of gastroduodenal artery embolization in particular. If varices need treatment emergently, we will do TIPS. And we mostly do TIPS for kind of elective cases where there's been recurrent variceal bleeding too. But we are increasingly doing some more Barto and Parto now as well. And Barto and Parto are the go-to in some other countries. So what about our patient? Back to wee Mary. So wee Mary had a CT scan that showed active bleeding at the duodenum, and she was taken for endoscopy, which diagnosed and treated a peptic ulcer in D2. Everything was dandy, but then 2 days later, she had another episode where she was vomiting blood again and was a bit tachycardic and dropped her blood pressure. She didn't have any further imaging. She went straight for a relook scope, but the scopist wasn't able to treat any further because the clot was so adherent and stuck down to the ulcer that they couldn't get at it. There wasn't any active bleeding at the time of the scope, and she'd stabilised with some resuscitation and things. So she was monitored overnight, and a kind of relatively elective empirical gastroduodenal artery embolization was performed the next day. And here are some pictures. So on the left here, as discussed, so we've got a bigger Muller catheter in the celiac axis here, and a little microcatheter coming out of the tip of it. This is the gastroduodenal artery. Here's an okay looking tube. Here is a blob. All right. And then this image on the right here shows you the coil in there to treat her. What else does Mary need though? Okay, so she's got a peptic ulcer, so she needs treated with whatever your H. pylori eradication therapy protocol is. Her HB after the first bleed and endoscopy dropped to 68, so she was transfused, so she'll need her hemoglobin to be continued to be monitored and might need some more blood. Embolization usually halts bleeding on the table. Okay, it's usually an instant gratification. Patient stabilizes, all is good with the world. But sometimes they can bleed again afterwards. And in those cases, you can go back and try and do a second attempt. Sometimes, though, surgical intervention is required, and there's not two ways about that. So that was a very whirlwind tour of GI hemorrhage. So let's just summarize. So GI bleeding can be upper GI, so before the ligament retreats, typically presents with hematemesis or melena, and is most commonly caused by peptic ulcer disease and varices. Lower GI bleed usually has fresher looking blood that's being passed per rectum, and the causes include diverticulitis, hemorrhoids, cancer, and angiodysplasia. Both of them are imaged with triple phase CT in the acute setting. Both require resuscitation, correction of coagulopathy, and treatment of the underlying cause. Both of them have endoscopy usually as the first line treatment. IR treatment is probably more common in upper GI bleeding and includes embolization using various methods, and for variceal bleeding, TIPS, and some more things that are often a bit rarer. And I need to give a special shout out to one of my consultants who sent me his GI hemorrhage talk for me to use some images and stuff from. So yeah, thank you in particular to Dr. Peter Douglas for that. And that's me, guys.